Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Bullets leave scars, both physical and emotional. And at hospitals across the country, including right here at the University of Kansas Health System, medical teams are constantly caring for people directly or indirectly impacted by gun violence. And now, more and more health experts are treating gun violence as a public health issue. Today, we learn what it means to approach gun violence from a public health perspective. We'll hear from a trauma surgeon who sees firsthand the damage that bullets can cause. I'm joined today by Dr. Robert Winfield, a trauma surgeon and division chief of acute care surgery at the University of Kansas Health System. Good morning.
Hi.
Hi, good to have you. And we also, you also actually went to a summit in Washington, D.C.
That's correct. Yes, I went to a summit at the invitation of the White House Office of Gun Violence Prevention.
Well, we are going to look forward to hearing more about that today. Olivia Damaris is a registered nurse with a master's in nursing and injury prevention education specialist. She'll explain a program that approaches shooting survivors while they're still in the hospital. How are you today? Good to see you.
Good. Thank you for having me.
Always good to have you on the program. So on one level, there is healthcare treating an individual, but then there is public health, which is health on a much bigger community level. Dr. Winfield, what does it mean to treat gun violence as a public health issue?
So I think oftentimes when we talk about gun violence, we try to boil things down into the presence or absence of guns. This really isn't the right way to go about this. Taking a public health approach means that we consider all factors surrounding an issue. And I think the other thing that when we talk about gun violence, people want to put it into boxes: intentional injuries, suicides, unintentional injuries, and make different arguments based on which of these we're talking about. Taking a public health approach means that we see these injuries and that we are attempting to try and prevent those injuries by looking at things that predated the injury. So presence of guns is one thing, but socioeconomic factors, environmental community factors, and so forth, making sure that we're exploring every avenue to potentially prevent an injury from occurring.
So you were recently at the White House, as we mentioned. Who else was at this summit, and what was the point of this gathering?
Yeah, so this was a summit put on by the White House Office of Gun Violence Prevention, and it was a gathering of healthcare CEOs and executives from health systems around the country. And along with trauma surgeons, emergency physicians, pediatricians, people who see the end result of gun violence. And so the thrust of the summit was really to get together these powerful folks in healthcare from across the United States to talk about these different approaches that people are taking to gun violence across the United States. And so in some areas, their emphasis was heavily on gun locks, for example, as a means of promoting safe storage and prevention of unintentional injuries and suicides in particular. In other centers, they were focused on socioeconomic factors and trying to invest in the community, making sure that the community that surrounded the trauma center, the places where their patients were coming from with gun violence, that there were educational and economic opportunities that were being created. And so, again, the White House worked with an organization that is recently formed of healthcare and healthcare system CEOs who are now coming together to share these best practices that they're implementing in their communities to try and prevent gun violence, which is an issue across the United States.
So much so that's important to point out that guns are now the leading cause of death of kids and teens in America. It's an alarming thing to say out loud, but it's the facts. So you've talked about kind of differentiating between incidental shootings, accidental shootings, and suicides. So again, just to reiterate, it is important, do you think, to talk about those differences? Because I think people think that they look at why this happened as a figure versus than just the fact that it happened altogether. So why is that so important to differentiate between the type of injury and where it came from?
Sure. I think there are different precursors to each of those things. And so, and we muddy those waters sometimes, mm-hmm. right? When you hear about a mass shooting, for example, lots of times people jump immediately to mental health. And certainly that could be a factor. Suicide, mental health is clearly an issue in that situation. And so it is important to differentiate, but recognize that there are also commonalities across these different patterns of injury.
And when you're treating somebody, it doesn't matter.
And that's a really important point, because sometimes too, when arguments get ugly over this topic, people say, "Oh, well, the majority of those are suicides." Those are people. Those are people that we take care of, that we see and we treat, and so these are people that society is losing. And so, from the perspective, at least of a surgeon, a trauma surgeon, seeing the end result of this, certainly the reason that they came in matters, but they're still all people in our community, people with families, people with friends, and the ripple effects of the damage that's done to them is astonishing. It affects entire communities when these things happen.
I'm glad you said that. Very, very good point. So in terms of frequency, which we don't like to talk about, but how often are trauma surgeons treating gunshot wounds here at this health system?
Yeah, so fortunately, gunshot wounds are not the most common thing that we see here. They represent overall somewhere in the 12 to 15% neighborhood of what we see in all trauma patients at the University of Kansas Health System, and we see about 3,000 injured patients a year.
And since you've been doing this type of work and this focus in healthcare, I mean, what have you seen from just even the last decade of the volume of patients we treat?
Yeah, it is so hard to parse out because the University of Kansas Health System has been growing very quickly, and so our numbers are going up, and so even though our proportion of patients who are injured by gun violence, and that includes all mechanisms of gun injuries, even though those the proportion has remained the same, the number overall is increasing.
But we're expanding and treating more people.
Exactly,
so
that's correct.
That makes sense. So we know that words matter. I've heard from at least one doctor who dislikes the term gun violence and prefers to say bullet-related injury because medically speaking, you're dealing with the bullet. It's not the actual gun that's causing the injury, especially with this being such a politically charged conversation. But what do you prefer to be it called?
I think that when we're talking about this, really violence is the issue. And again, even in the case of a suicide, a gunshot to the head is a violent way to die. And so I prefer the term violence. And I've mentioned in other conversations that if you were to magically, snap your fingers and every gun in all the world went away, there would still be violence. We would still see people who were stabbed, people who were beaten, and so violence itself would not go away. So guns are one component. They were particularly lethal and severe injury-causing component, but they are not the root of the issue. The root of the issue is violence, and I tend to focus on that. So
you and Olivia both are part of a program called Thrive, which stands for Together Helping Reduce Youth Violence for Equity. Dr. Winfield, how did Thrive start? What does it do?
So I will give a hat tip to my good friend Dr. Jamela Watson-Thompson, who is really the person behind Thrive. And she's not able to join us this morning, but Dr. Watson-Thompson essentially has been in the Kansas City community across state lines for many years. But she works at the University of Kansas Center for Community Health and Development on the Lawrence campus of KU. And what she has done is collated resources in Wyandotte County. So she's gotten together charities, faith-based organizations, law enforcement, the judicial system, and has put all of these people in a room together and said, how do we stop violence from happening in our community? If we have people who are at risk, what sorts of things do we plug them into to try and prevent violence from occurring? And so this includes things like after-school programs. It includes finding jobs for kids, arranging transportation, helping with safe housing, addressing food insecurity. And so really what it does is take all of these folks in the community who are trying to do good things on their own and brings them together to try and address the issue of youth violence in Wyandotte County.
And I think the community loves hearing the behind-the-scenes story because it's easy to just say, not enough's being done. But the fact is things are being done, and it takes time, and it takes a village. So Olivia, part of Thrive is REVIVE, which is another acronym. This stands for Reducing the Effects of Violence Through Intervention and Victim Empowerment, and it involves reaching out to shooting victims directly. So you all do that. What's happening and what's the goal?
Yeah, so Thrive is where REVIVE started. Dr. Jamela Watson-Thompson identified a hospital-based violence intervention program as an important factor to have for the community. So that's where REVIVE was born. So we came together with various collaborations in the community, and what we do is we have folks from Ad Hoc Group Against Crime, and they have case managers on staff. So when they are notified when a patient comes in who is a victim of violence, not specifically gun violence, but it can be any sort of violence. It can be a stabbing or a beating. But if a person comes in ages 12 to 24 and is a victim of violence, those hospital responders from Ad Hoc Group Against Crime are notified. And when they're notified, they then come to the hospital and come to the bedside and offer services to that patient and their family.
Why is it so important to get to them as quickly as possible? Right there at the bedside, they're handling, they're going through a lot.
Yeah.
But knowing that you're there and capturing them in those moments, I would imagine would be pretty important.
Yeah, amongst hospital-based violence intervention programs across the country, we call it the golden hour. It is that time where people are feeling vulnerable, they're feeling lost, and we want them to feel supported and taken care of. And so by having those folks in the community who are absolute experts at where they can get access to safe housing, food, educational programs, housing stability, whatever they need, whatever they have identified as a need for that patient or family, that they have a case manager out there in the community that's going to follow them for 6 months and help them reach their goals and help them reach what that next step is after their injury. And the whole thought is that if we are addressing their social determinants of health, as Dr. Winfield had talked about, that they're going to feel more safe and secure in the community. They'll be less likely to either be re-victimized or retaliate for their injury.
And how do patients usually receive that information at the bedside? What are those conversations like in the moment? I would imagine it's patient-to-patient basis.
It is. It's very, very patient-to-patient specific. I know some families have just been overwhelmed with the support that we can give. For instance, there's been people who go back into the community and they're wheelchair bound now. They don't know how to get into their house. We've been able to coordinate contractors within the community come build a ramp for them, free of charge. Like, these are the type of things that Revive is giving to the community and to our patients, and we want to be able to provide those services when needed. Now, not everybody is open to, having that kind of help. I think there is a lot of skepticism, which is understandable, and so we leave them with their information. We say you can call us back at any time. You can re-engage whenever you'd like. Our case managers are so great at following up and continuing to engage with folks. So if there is a need a month or 2 or 3 months down the line, that they can still re-engage and get the services that they need.
Follow-up is key. Dr. Winfield, how important is it to reach these patients and try to stop the cycle?
Yeah, it's critical. Again, these patients are coming in, and as Olivia pointed out, some people are not receptive, but most good evidence would support that when you have a patient in the hospital, you have this this golden hour, golden moment for intervention, and being able to reach people at that time, even if they're not immediately receptive, when they know that support's out there, they do circle back to us, and they do say, you know what, now I could use some legal help, or I can't pay my bills because I'm injured and I can't work, and they realize at that point, okay, that person said they could help me, and we do.
Well, there's a lot to get your head around, and building a ramp into your home is certainly the last thing you're thinking of when you're just trying to survive and make it out of the hospital. Not until you need those services do you think about it, but to know that you were there to talk about it, then they do circle back. So what's trauma-informed care, Olivia?
Yeah, trauma-informed care. I feel like it's kind of a new way of thinking about how we should interact with everybody. I don't think it's specifically just hospital-based. We talk about trauma-informed care. I know my kids' teachers are talking about trauma-informed care. And the whole thought is that everybody has their baggage. Everybody has had traumas to their life. And when I'm talking trauma, I'm not talking gunshot wounds. I'm not talking beatings or stabbings, but we have all had trauma in our life. We've had loss of homes, or maybe financial instability, or we've been through a tornado or a hurricane. All of those things leave us with little bits of trauma. And so therefore, the next time it storms, this person might have a disproportional reaction to a storm that comes through because they had previously lost their house to a tornado. And so for us, and the way that we want to interact with everybody in the community is to come through it with a trauma-informed lens, so that way we understand that everybody has their baggage, and that when maybe somebody's reactions don't align with what we expect, to take a deep breath, to empathize, and to say, well, we don't really know what's going on with this person right now. We don't know what their history was and what their experience is. So instead of telling them, hey, it's just a storm, no big deal, what we should say is, oh, you seem really upset. Is there anything I can do to help? Should we pull the blinds? Should we do something different? You know, there's different ways that you can approach people in a trauma-informed way, so that way we're not minimizing or negating people's trauma, but we're trying to empathize, understand it, and work with them to deal with it as they're feeling it.
Well, we have more questions for both of our guests. Be sure to ask your questions. You can use the chat on YouTube or Facebook. You can email the Medical News Network. The information is right there on your screen, so get those questions sent in. Gun violence affects different communities differently, and I would imagine for some people they see it on the news, kind of not in my backyard, so they don't feel that guns and violence affects them directly in their communities. So Dr. Winfield, what is your response to that train of thought?
Sure. So I tell people fairly frequently that if one of us is unsafe, then all of us are unsafe. And I don't think we have to look too far in the history of Kansas City to see an example of where that happened. And that's the Kansas City Chiefs Parade. Okay. Mm-hmm. I don't know if you were there. My family was there.
My kids were, yeah.
I was there too.
You were there, yeah.
So we all had folks. My kids don't go to sleep at night hearing gunshots in the neighborhood. They don't worry on a daily basis about getting shot. So you're correct. Some communities, that's the case every single night. You know, these kids are growing up in environments where they do hear those things. They see these things. My kids don't worry about that. Okay, but they go to the Kansas City Chiefs Parade, and my understanding of that incident is that violence breaks out. It was not an intentional event. It wasn't targeted at the Chiefs per se. This was community violence that broke out in a setting where there were lots of people who don't think about this on a regular basis. And as long as that exists, you can be anywhere. You can be at a shopping mall. Your kids can be at school. All of these places are potential areas where violence can occur. And I think, again, that sort of should bring it home for most people, that this does happen here, and although it doesn't happen in your neighborhood on a nightly basis, it can absolutely directly affect you.
It doesn't happen until it happens,
yeah.
And then you've got to start dealing with it. Let's talk about the bullets themselves, because we know it's not the gun causing the injury, but the bullet itself. Oftentimes the bullet fragments or the bullet itself is still left inside a survivor's body. So just the presence of that bullet or fragments inside a body, what kind of damage is that causing immediately and then down the road, Dr. Winfield?
Sure. So I think one thing to think about with this is when we operate on people for a gunshot wound, and the bullets are lodged in various places, and so in our heads we have to kind of think about the risks and benefits of, do I go after that bullet? Because sometimes it's much riskier to go in and dig something out. You can create more organ damage and so forth to go after it. Now that said, psychologically, agree. There's still a bullet inside someone's body, and they know that. Mm-hmm. People will ask, "Did you get the bullet out?" And so psychologically, there's an effect. I think physically, though, there has been some data where people have looked at this, and long term, there is leakage of heavy metal, lead, and so forth into people's bodies, and so it actually can have physical effects as well. But again, we have to weigh that against the short-term risk of, for someone who has a bullet and doesn't need an operation, do I then put them under anesthetic and go digging around in some place where I can cause bleeding and infection and so forth, or is it safer to leave it in place? And again, that's a case-by-case issue. So.
And what are those conversations like with a patient? They come out, they just want this out. Is there ever a time when you would say, right now it's not safe to pull it out, maybe it would be down the road, or is it like trying to explain to them, actually, you are safer and healthier with the bullet staying where it's at?
We do, and sometimes what we'll have to do is explain the operation that would be required in detail to explain, what would be necessary. And most of the time, people are understanding of the fact that the risks of the circumstance outweigh the benefits. There are times we take out plenty of bullets in our clinic. Patients have a bullet that kind of works its way out to the surface, and once we can feel it, then that risk-benefit equation shifts in the direction of, okay, there's a benefit here. This thing, you can see it. It's causing pain for you, and that sort of thing. And so we certainly do take them out. But again, it's kind of a case-by-case situation as to whether or not it's the right thing to do.
Olivia, what have you noticed just in the mental health aspect of somebody going through a massive physical trauma, through an injury like gunshot, knife wound, anything like that? You know, where do we stand with that? How do we help people kind of make it through on the other side?
Yeah, and I think Revive is the answer to that. One of the biggest things that Ad Hoc Group Against Crime offers is counseling. They offer free counseling for any of the Revive participants. Because it is a trauma, and you know, moving forward after trauma can be really difficult. So having the community there to support you and not having to worry about some of your basic needs because they've been taken care of, and then you can focus on that mental health piece of healing, I think is really helpful.
It's a process.
Yeah,
It's a process.
It's a process, for sure.
So one of the simplest things that gun owners can do is store their firearms safely. Is it fair to say that unsafe storage is part of the problem? One part of the problem?
I think so, yes. I think, you know, having young children have access to guns. Dr. Winfield mentioned earlier about suicide, just having that one barrier that you have to go and find the key to get the lock, storing your gun separate from your bullets, having to go 2 different places, gives somebody a second to pause, a second to think. You know, it's a lot of times those decisions are made emotionally and very quick. And with a lethal means like a firearm, there's no turning back.
Yeah, good point. Just creating one barrier.
So just creating a simple barrier between there and pulling the trigger it can be the difference between life and death. So absolutely, safe storage is a really, really important thing. Now, I will say that I think there is a component to it that we have to, as a culture, accept that our guns are stored safely, and that it's not going to be there at the ready in case we need it. And I think there's a lot of folks that makes them uncomfortable. So while gun locks are free and we can give gun locks away to people, we need to be able to change the way we think about our weapons and how we store them. So that way we can understand that there's probably a higher likelihood that we'll have some sort of mental health episode, that we need to have some sort of barrier, some safety there. Versus having, you know, an intruder come into our house and then we need that weapon to protect ourselves. And that's a thought shift, and that's not as simple as giving away free gun locks.
It's not. It's not. Dr. Winfield, tell us about Stop the Bleed, this type of training, and how much of a difference can it make?
Sure. So I think it's important for people to understand that Stop the Bleed actually emerged after the Newtown, Connecticut school shooting. And what was recognized is that there are opportunities early on. The leading cause of preventable death and trauma is blood loss, hemorrhage. And so the Stop the Bleed program, the idea behind that is to bring trauma care to the community, in that if someone has an injury, primarily to the extremities, arms and legs, that if a patient is bleeding from that, if you can apply pressure or apply a tourniquet, that may be enough to hold off that hemorrhage until the person can get to the trauma center and have definitive treatment for it. And so much in the way that basic life support has been promulgated throughout the community, this is essentially trauma care for the community. It's not really specific to gun violence. People can have injuries. We see people come in with tourniquets after motorcycle crashes and they're bleeding from their leg. And so the idea here, though, is that whether shot in the leg or in a motorcycle crash, that these people are bleeding, and if we don't stop that bleeding, they are going to die. And so the Stop the Bleed program is really designed for bystanders to be able to apply those treatments. And so in terms of effectiveness, these are always hard things to prove. However, tourniquet use has increased in the United States substantially, and both by pre-hospital and community members. And so with that, we are seeing less people coming to the trauma center in extremis, like on the verge of death, because of blood loss, because these patients have had tourniquets applied or someone new to apply pressure to a bleeding wound in the field. So it's a great program.
Would it be fair to say it'd be something like everybody having CPR training? If everybody had tourniquet training, that would give you extra minutes to be ready when somebody comes through, ultimately possibly saving lives, right?
That's correct. And you see programs across the country now where people are putting Stop the Bleed kits next to the defibrillators where there are packing materials and tourniquets and gloves and things so that that we can apply these Stop the Bleed techniques all across the community, just like you're describing.
Olivia, I saw you shaking your head like,
Yeah.
yes, we need more people to know what this is and to be able to step up like somebody would on the street giving somebody CPR. Anything you apply, any pressure can help on the back end.
Absolutely. I think it's also important to point out that you can put a tourniquet on yourself.
Yeah,
They're
yeah.
designed so that way, and they were designed, in the war, that this is something that every single soldier carries so that way they can apply to themselves if they need it. My brother, he said he was going on a big hunting trip out in Montana. He got a tourniquet for a gift because I wanted him to be able to save himself out in the wilderness on his own.
A tourniquet as a gift. You do
Yes,
not
I
hear that
said-
very often. I like
said-
this.
It was his. He said, "Hey, I want a first aid kit," and I said, "I got you, buddy." Like, yeah, So for Christmas, I put together a whole first aid kit, including a tourniquet, so that way he had what he needed in case he needed it. Thank God, he's never needed it, but it's there. My husband, he carries one when he goes duck hunting. My dad has gone on motorcycle trips, and I expect him to carry it out with him. It is just one of those things that you have on hand in case you need it, and you hope you never do.
My kids keep them in the car. They have them in their backpacks.
Yep.
Really?
My kids, yeah. I mean, my
I take one
youngest
when I
child-
ride my horse because you never know.
Yeah, my youngest child's 9. She knows how to put a tourniquet on. So
Okay, where do we get them? I'm like, whoa, hold on. Okay, so this is something I have a 8 and 11-year-old. Is this something they should know how to do?
oh yeah.
Yeah.
Okay.
And
Absolutely.
again, it's very straightforward in what to do. Now, we have no illusions about the fact that this is going to be pretty hard for somebody to do when they really see somebody bleeding. However, the techniques are very simple to learn, and so we teach these to kids at schools. We teach them to really any community member that asks, but it's very easy to do, and yeah, you can buy a tourniquet on Amazon. It's the very same ones that my kids have.
Okay, so but what if you don't go through a program? Is this something you can just learn? How do you learn how to do it if you're not going through one of these programs?
So there's some really great videos that are online.
I was going to ask, go online.
So FEMA actually has a "You Are the Help Till Help Arrives," and they go through tourniquet application there. So I would encourage you to look at FEMA and their emergency preparedness pages because they have a whole curriculum on "You Are the Help Till Help Arrives." It's virtual, online, but we also have Stop the Bleed classes here. So if you do want an in-person class, we have and offer classes. We come out into the community. We come to we've been all over to different job sites have had us come on board, schools, Boy Scouts, Girl Scouts,
The legislature. We
the
go
legislature.
to Kansas State Capitol.
Yeah, you can always contact the health system. Israel Mendoza is the one who really leads the Stop the Bleed program here at the health system. And yeah, you can reach out to us and we'll schedule a class for you. But if you're not into the in-person thing, there are virtual resources that you can look
And
at.
anything helps. Okay, I've got lots of things in my Amazon cart.
Yeah.
I will add 2 tourniquets for the kids
Yep.
in my Amazon cart. Thank you both for that. I think that's a good takeaway today. So let's get to some questions from our viewers. And Stuart wants to know, has Dr. Winfield worked in other cities, and how do you think gun violence compares to Kansas City?
Sure. So prior to coming to KU, I worked at Barnes Jewish Hospital in St. Louis. They have a substantial gun violence problem in St. Louis as well, in terms of interpersonal gun violence. I will tell you the other places where I trained and worked, the University of California, San Diego, gun violence not as much of an issue. University of Florida in Gainesville, it's college town. There's a little bit of gun violence, but not a whole lot. But certainly St. Louis and Kansas City are 2 cities that share an issue with interpersonal gun violence.
Barsh has a question. What do you both think the parents and communities can do to work on this violent issue? There seems like a lot of people are a lot more on edge. There's so much more stress, dehumanizing people out in public and traffic, and you've got road rage and all sorts of things in our culture. But just could you comment on what people can do, the regular person who isn't expecting it but can kind of be part of the solution?
I think, excuse me,
Please.
Conflict resolution. Teaching our children and being kind to one another, approaching all of these conflicts with a trauma-informed lens, where instead of reacting emotionally, seeing somebody react emotionally and meeting that energy with that emotion, if we can just pause, take a breath, and focus on how to resolve the conflict without violence, I think that's really what we need to focus on. And I know I have a 7 and a 9-year-old, and so I spend daily conflict resolution, working through problems, and I think that that's just something we really need to take head on as parents, as family members, as community members, making sure that we can work through these conflicts in a meaningful way.
Dr. Wingfield, what can we do?
Yeah, I like that a lot. I'm a big Ted Lasso fan, so be curious, not judgmental, is one of Ted's most famous lines. I think that's important to Olivia's point. Learn, stop the bleed. Again, it's not usually a matter of if, but a matter of when, and I bring up the Chiefs parade again to talk about that for our community. But the other thing is there are lots of people in the community working on this, and certainly if you reach out to me or reach out to Olivia, you want to help out with these community agencies that are assisting with violence in our community. They're happy to have your help, whatever that looks like, donations, participation in programs, and so forth. And so there are lots of people working on it. You're not doing it alone. Go ahead, join up with us and make this community stronger and safer together.
If you could drill down the biggest takeaway from today's conversation, what would it be?
Again, if one of us is safe, none of us are safe is really, I think, the biggest thing from my perspective. We do tend to think of gun violence as something that happens to someone else somewhere. Trauma in general is like that. People, I'm never going to get in a bad car crash. It happens, and it can happen to you. And so the best thing we can do is to recognize that this is affecting all of our community, even if it's not affecting each of us individually on a daily basis, and figure out what our contribution to addressing that looks like.
Olivia, what's the biggest takeaway?
Yeah, I think it's knowing that we do have resources. There is help. Reach out if you need some help. There are programs like Revive that are there. Anybody who comes through our health system as a victim of violence, I hope that they do engage with Revive because we want to help. And then, let's just change the tone of the way that we talk about these issues because it is a public health issue. Yeah, we are all affected by this, and so if we can just approach it in a little different way, I think we can make some big gains.
Really great, really important conversation today. Thank you to you both. Appreciate it. Thanks to all of our guests and to our viewers for being with us. We'll see you back here on Wednesday. Coming up Wednesday on Open Mics with Dr. Stites. Kids want to eat what kids want to eat, and research shows their food choices are driving the childhood obesity epidemic. I'm Jessica Lovell on the next Open Mics with Dr. Stites. We explore a first-of-its-kind study empowering both kids and parents to take control of their health. Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.